That's okay. Okay, so let's go ahead and start. So I think the first thing we need to look at is whenever you're talking about cross-section anatomy, you still want to refer back to the patient's body as being like in the normal anatomical position. So if you remember back in X-ray school, when that was taught to you guys in the very beginning, normal anatomical position always starts with the person being upright, so they're erect, they're facing forward, right? Their arms are just slightly abducted, which means away from their body a little bit. So just out a little bit, and then the palms are turned outward, and the head is looking forward, and the feet are facing forward. And if you start that, that's a good reference point. So I always want to start right there. Let's talk about the planes first. So the body can be separated in different planes, and when you say plane, it's almost not like an airplane, it's like a plane of glass. So if you can imagine a plane of glass or a straight sheet, like a sheet of plywood, going through the person and separating the body into different sections. And that's kind of how CT works, and that's how the images get reformatted. So we're going to be talking about the axial plane, which another term for that would be transverse, and another term for that would be horizontal. Those three terms can be used the same way. And then we have coronal, which you may hear the term frontal used. And you know the term mid-coronal is very similar, but mid-coronal would, as soon as you throw that term mid in, it means equal sections. We also have sagittal and mid-sagittal, and again, mid-sagittal would mean an equal section. And then we have oblique planes, which are rarely used, but can be helpful during reformats. And then we have 3D. We're going to talk about each one of those individually. So let's take a look at the first one. The first one that we're going to talk about is axial, transverse, and horizontal. So that plane will divide the body or the part into both superior and inferior sections. There really is no mid-axial plane, by the way. There's axial, transverse, horizontal, all means the same thing. And I put most or just about all CT scans are going to be acquired in that plane. Like you still may go somewhere that says, get me a true coronal of the sinuses, but probably not. So when you're going to obtain your initial scans, they're going to be obtained in that plane, axial, transverse, or horizontal. I always like to use the loaf of bread analogy. So there's a little picture up in the right-hand corner that shows the patient's body like a loaf of bread. And you can imagine the top or the vertex of the head being a heel, all the way down at the bottom or the plantar surface of the feet being the other heel, and the entire body would be the brown colored loaf of bread. If you were to take one slice of that bread out and look at the white on the inside, that would be your axial, horizontal, or transverse section taken out, and you can look at that, just like it shows the piece of bread. All three of these are representational of axial planes. So when you scan your head, it's going to come out looking like an axial. And when you look at that axial scan, anything at the top of the screen that you're looking at would be things that are on the front of the patient or the anterior. So things that are up here like the frontal sinus or the frontal bone of the head, that's on the anterior of the person, right? This would be the middle section, and anything down here would be posterior. Same thing with the chest. So when you're looking at an axial of the chest, anything that's up here near the top is on the front of the person. Something right here in the middle would be in the middle, and then anything down here would be posterior. When you're looking at this axial section of the abdomen, it's still the same thing. This is the anterior of the person. This would be the posterior of the person. This would be located in the center or in the center of that slice of bread. Also remember when you're looking at that axial image, it's hung just like an x-ray, which means it's going to be on the x-ray monitor like a mirror. So when you look at the right side of the monitor, it's the left side of the patient. Or the left side of the monitor is the right side of the patient. Okay? It's like a mirror image. Right is on the left. Let's look at coronal sections. So coronal sections are sections that divide the body or part into anterior or posterior sections. So you remember, it's got to be like a plane of glass or a sheet that's going through the person that's going to separate front to back. And I used this picture up on the right from 13 Ghosts. It was a horror movie that I liked. And you can see the plane of glass drop straight down to the person. The front of his body slid off, and you can see inside, and his body's getting separated into anterior and posterior sections. You know, when you're talking about CT, though, you won't hear the term mid-coronal as far as looking at images. It's hard to tell if you're exactly mid-coronal when you look at your images. Yeah, you can go back to your tope and see your reference line where it is, but you'll hear just coronal section. The time when you might hear mid-coronal in CT is when you're positioning the patient. Like they may say, put that lateral centering line along the mid-coronal plane of the patient, so you know that you're centered right top to bottom. That's when you're going to hear it. When you're looking at images, you're just going to hear the term coronal. The anatomy that you see on a coronal plane is similar to what you would see when you look at an X-ray, like in an AP or PA projection. So it's real easy to look at coronal planes. It's easier for your eyes because your eyes are used to seeing things in like an AP or PA projection. So the organs kind of look the same way they would on like a chest X-ray or an abdomen X-ray. It's still going to be right on left. So even when you look at a coronal, the right of the patient is still going to be on the left side of the monitor. Like this right here would be a face, and you can tell it's a coronal because it looks like the face got cut front to back, or you can see things that would be in the same plane going across the patient. Like you can see the orbits at the same time as you can see like the maxillary sinuses at the same time that you can see part of the teeth. So it's all like straight down. Chest, same thing. Abdomen, same thing. This one on the right, the far right, that is the abdomen coronal, and you can see the spine. You can see the kidneys. Is that in the front or the back? Or is it in the middle? This one on the far right, this image right here, would that be taken, like, is that a coronal section that's on the very front? Would it be in the middle, or would it be more towards the back of the patient? Probably a little bit more towards the back, because you know the kidneys are a posterior structure, right? But they do sit a little bit anterior, and the lumbar spine does curve almost to mid-coronal plane, doesn't it? Back when you went to X-ray school, didn't you center for lumbar spine right at the mid-coronal plane, front to back? So the middle part of the spine does project, so it's probably middle, but a little more towards the back, since the kidneys are showing up real nice there. And then we have our sagittal section. A sagittal section divides the body into right and left halves, or right and left sections, I should say, because a half would be equal. If you said mid-sagittal, that would mean right down the center of the body or part. I like that little image of from the Terminator where the guy got split right down the middle of the head. That's pretty cool. So his head got split into right and left halves. When you look at a sagittal section, it kind of looks like a lateral X-ray. So you can relate back to X-ray school for that. So sagittal kind of looks like a lateral X-ray. It would look like a lateral skull or a lateral thorax or like a lateral projection of the abdomen. Oblique plane. Oblique plane is any plane through the body that is not parallel to one of the other planes that you just learned about. So it's kind of going through the body or part at an angle. I really don't think it's possible to scan like the vertebral column in an oblique plane unless somebody's got some kind of weird twisted up scoliotic spine, right? We normally scan people in the axial plane. That's the way they get scanned. That's the most common scan way. When you do your reformats, however, you may reformat in an oblique plane. Like one thing that comes to mind is temporal bones or mastoids, because they don't sit exactly like at a 90-degree angle to the body. So if you look at the Petrus pyramids that house the temporal bones, they're kind of at angles. They're like 45 degrees. So to do true reformats on temporal bones, yeah, you do the scan axial, but then when you do your reformats, look at these lines. See how they're going parallel along the temporal bone right there? That helps them to come out to look like a true coronal, okay? Even though it's being reformatted in an oblique. But you're never going to put a patient on the CT scan and they're not going to say, scan that patient in an oblique plane. It just doesn't happen that way. Might look that way, but it doesn't happen that way. I put this one on here for a reason. Sometimes people's pelvises aren't straight. Sometimes they can't lay flat. Sometimes one hip's cocked up. And when you do your initial axial scan, it's not symmetrical, okay? So when you go to do your reconstructions, you may reconstruct it oblique, but then the actual finished product, the coronal that comes out, may look nice and straight. So that's when you may have to oblique your reconstructions. And 3D. 3D is technology that allows you to view and inspect external and internal structures of an object in 3D space. So it takes a two-dimensional CT and it makes it look three-dimensional. The doctors really like looking at those because they look cool. They don't get a ton of diagnostic information from them. Like, for example, look at the one on the far right. It's showing you blood vessels, and you can see an aneurysm real nice. See that bubbled out area? You can see like an aneurysm because it's like a balloon, right? It stretched out the wall of the vessel. The vessel got a little bit bigger than what it normally is. But the downfall with that is you can't see inside. Not with that type of reconstruction, you can't. There are some 3D ones that do allow it, but for the majority, you can't really see inside the vessels. You just see inside the body in a 3D dimension. It's real good at looking at fractures. Like orthopedic surgeons like to look at like heel fractures in 3D, trimalleolar ankle fractures, you'll scan those in 3D, hip fractures to look for how the fracture fragments are separated anteriorly to posteriorly or obliquely. And then it's good at looking at other vessels too. Like CTAs always look nice. Okay, let's go on to head. So axial. So here's some stuff that I would like you to get out of this. And I'm going to bring up some images that show you what I think it's helpful for you to identify. So just throwing you guys out to clinical without having a little bit of cross-section, I think would put you at a disadvantage. But if you have some cross-section under your belt, when you first start doing easy things like head scans and chest scans and just dry bellies and stuff, at least you'll be able to recognize the common stuff. So bones, gray and white matter in the head, ventricles, the different lobes of the brain, the choroid plexus, gyri and sulci, the falx and the cerebellum are all things that I think you should be able to identify pretty easily. They're things that kind of just snap right out at you on the CT. You don't have to like look with a magnifying glass to find these things. So I have about four, maybe five axial cuts that we'll look at. And I think it's important to be able to like, not just those things that I gave you, but a couple other things to be able to identify. So when you look at that first axial scan that comes up over here on the left-hand side, there's a small little white area on the very outside. I mean, here we got a black area of air where you're scanning nothing. And then you come to your first little thing that's white. What is that? Skin. That would be skin. And then directly under the skin, you got another layer of fat. That would be the scalp. And then you get into bone. Okay? Then you have your bone. Then you have your brain tissue in here, which it's always easier to figure out what you're looking at on a head CT if you start looking at the top, because there's not as much going on up there. The top of the head, known as the vertex, there's not as much stuff up there, right? So anything up here by the arrow would be stuff that's on the front, and over here would be more towards the back, and then over out here would be stuff towards the sides. Also remember that axial plane that you scan the head or when you do your reformats in always travels like along an imaginary line from the skull base just through the bottom of the orbits. If you could position a person like perfectly for a head CT, you would want to tuck their chin down so their IOML is like perpendicular to the floor. The reason we used to do that was because all the scans, when we first started doing CT scans, we wanted the scans to go directly through the skull but avoid the eyes. We couldn't tilt the gantry at all in the beginning. So and then the radiologist got used to like viewing CT scans in that axial plane from the skull base to the orbit. And you can see it down here. If you took this line right here and followed it down this way, that's where it would go. It would go from just below the orbits right down through the base of the skull. So when you put your cut lines in, that's kind of what you want to, that's the way that you want to do the scan. Or when you do your reformats, that's how you want to reformat it, from that way up. That way it always looks the same when the images come out. Okay. As far as the bones of the skull, frontal bone up here in the front, and then the rest of this is all parietal. It really hasn't hit the occipital bone yet. So frontal bone, parietal bone, and then the lobes of the brain go right along with the bones that they're sitting next to. So the lobes of the cerebrum, you got the frontal lobe, right? You got parietal lobes, you got temporal lobes, got occipital lobes, and then you have one that's internal also. Don't have to worry about that yet. Cerebellum's a whole different thing. So we got the frontal bone here, which means this would be the frontal lobe of the brain, and because these out here are the parietal bones, this would be the parietal lobes of the brain. You do have a structure that separates the two, and it sits right within the longitudinal fissure. That's like an area that's like right in between. It's like a groove or cleft in between the two halves of the brain. You know when you see a brain on TV, or sometimes you'll see one at the supermarket, it's sitting there, it's got two halves. Well, there's a fissure that kind of runs in between, and then the structure that is like a fiber structure that separates this white thing, that's the falx cerebri. That's something you should be able to identify. Okay? The older you get, the more calcified it gets and the brighter it gets. It also kind of highlights, that area kind of highlights a little bit when you inject heads too. So that's your falx cerebri in the middle. And then you got gyri and sulci. So that's like all the squiggly parts that you see on the outside of the brain. The thicker folds of the brain itself are called gyri. So when you look at this, you got these light gray folds all kind of going around this way. And then you also have black little areas in between. The black areas in between are the areas that have a little bit of spinal fluid, and they're called sulci. So gyri are the folds, the area between are sulci. You may hear gyrus. You may hear them called gyrus, and it's the same thing. So gyrus or gyri, sulci or sulcus is the same thing. If you go down just a little bit further, you can still see some of the same stuff. So you can still see the frontal bone here, you can still see the parietal bones on the side, and then also you're probably starting to get into the occipital bone right here in the back. So 3 different bones that you're seeing, and you're also seeing 3 different lobes of the brain. So you're seeing frontal lobes here, parietal lobes here, and then in the back, the occipital lobe of the cerebrum. Okay. Still seeing that falx separating the two. And then you can also start to see a big difference between gray matter and white matter. Gray matter on CTs shows up light gray. So you can see the gray matter is this outside portion, and the darker area in here is all considered white matter. So white matter shows up dark gray, and gray matter shows up light gray on CTs. If you look at an actual brain, the outside, the pink part would be the gray matter, and if you sliced it and looked inside, the white part would be the white matter. And then if you go down a little further, you're starting to see these big darker areas. And those are called ventricles. So you actually have 4 ventricles. The first 2 are known as the lateral ventricles. They're the biggest ones. And then you have the 3rd ventricle, and then the 4th ventricle is all the way in the cerebellum. And those are places that hold spinal fluid. Also within the ventricles are these vascular areas, and they're called choroid plexus. They also calcify super bright when you get older, and that's where the spinal fluid's made. So it's made in the choroid plexus primarily of the lateral ventricles. The other ones have them too, like the 3rd and 4th have them, but they're really small and you rarely ever see them. Still got the same bones going on. You still got the frontal bone, you still have the parietal bones on the side, and we still have the occipital bone in the back, which means as far as the lobes, the frontal lobes, the parietal lobes, and the occipital lobes of the cerebrum in the back. You still have the falx cerebri in the middle too. And then if you go down a little further, you get that area where you get the smiley face. When you see the smiley face, you're starting to get into some new stuff. So you still got the frontal bone out here in the front, and you still have the parietal bones on the side, but you're starting to get into where the parietal bone ends, and you're getting down a little bit lower to where the temporal bone starts. So I always know when I see the smiley face, I'm starting to leave the parietal bone and enter the temporal bone. You're getting really close. And you're going to start to see the petrous pyramids coming in if you went down a little further. You would know you're really into the temporal bone then. And you still have the occipital bone in the back. So we have frontal lobes, parietal lobes, and occipital lobe to here, but then you got this weird looking thing projecting up in the middle. That's actually the cerebellum. It looks different, and it's kind of tucked up under the cerebrum. You can see it a little bit there. These dark spaces here, they're still part of the lateral ventricles, and they're horns. So the lateral ventricles has anterior horns, temporal horns, and posterior horns. Posterior horns were here. These are anterior horns up here. Let's go down a little further and finish up these axial heads. So a little bit further down, you still got the frontal bone here. We still have, you're starting to see parts of the sphenoid bone in there, and then you get the temporal bone here in the back. There's your 4th ventricle down there at the bottom. Remember I said you had 4 ventricles? So that's the 4th one right there. If you went back to this cut, that would be your 3rd, and then these are still part of the lateral ventricles. So occipital bone in the back, temporal bone here, sphenoid bone there, frontal bone there. All right, I think that's about it. Let me just go back and make sure we took a look at everything. We looked at the bones, we looked at the white and gray matter, we looked at the ventricles, the lobes, the choroid plexus, the gyri and sulci, the falx cerebri, and of course, all this back here is all cerebellum, by the way. 4th ventricle located within that. So we covered all that. Any questions on the head? As far as the thorax, what I think is important to be able to identify: skin, fat, muscle, bone, organs, and air. And then the heart, pulmonary trunk, because you'll be doing chest CTs probably right away. The aorta, trachea, esophagus, and then just like your great vessels. You don't have to know exactly what everyone is, but let's just take a quick look. That's a thorax, right? That's an axial cut. This would be the patient's right side over here. This would be the left. This would be the front. This would be the back. So all the way out here on the edge is your skin, and then you're going to have a fat layer. So fat kind of shows up dark gray on CT. All this light gray is muscle. So basically muscles and organs kind of show up kind of light gray on CT. And then you got white. If it's bright white, it's probably either bone or contrast if the patient was injected. And then anything that's real dark is air, like in the lungs. You can see some ribs in here. These two little points. Two little points sticking up here in the front. That's the medial ends of the clavicles. Yeah, sticking right there in the front. And back here is the scapula. You see the acromion process way out there, the spine, the body, and there's a vertebral column there. How about this big hole? Air-filled trachea, right? And then right behind it, see that little thing that's gray? What's that? The esophagus sits directly behind it. Esophagus is rarely ever air-filled, plus it collapses. And unless you drink barium, you're not going to see it. You just see a little piece of gray behind the trachea. So you know where it is. And this looks like a small gray piece. This is important because that's a little bit further down, and you're seeing, with contrast, that's the pulmonary trunk. So when you guys do CTAs, you have to be able to locate that. Look what it's at the same level as. What are these two dots here? See these big black holes? The trachea goes down, and the trachea stops, and then it splits into two bronchi, right? Right and left main stem. What's the bifurcation called? The carina. So the pulmonary trunk is at the same level of the carina. So when you do a topogram, you find the split of the trachea, you know you're going to put your line there for your ROI section to find your contrast. And then you got some ribs here. This is all part of the heart in here. And your aorta, the big blood vessel right there. Remember, the aorta's got a ascending, an arch, and a descending, a part that goes down. And then a little bit further down, you can see breast tissue, you can see the heart, you can see the aorta, you can see the spine, and you can see some ribs and lung markings. Let's make sure we got it all. I think we did. It's pretty quick. Yeah, we did. Let's go to abdomen. Looks like a lot, but we'll cover it pretty quick. So liver, spleen, stomach, pancreas, kidneys, psoas muscles, adrenal glands, aorta, IVC, bowel, bladder, and rectum. Doesn't sound like that much, does it? It's all stuff you already know. So there's a section below the diaphragm, shows you a lot. Again, on the very outside, you got skin, you got fat, you got muscle, and then you have fat also within the peritoneal cavity or in the abdominal cavity. You got some fat. Over here in the right upper quadrant, one of the largest organs, that's your liver. You got your spine in the middle, kidneys on each side, some air in the stomach, spleen. Spleen's on the left side. It's a posterior organ. Remember, when you're looking at a CT, things that are on the patient's right would be on your left, vice versa. Pancreas sits kind of in the middle. Aorta, inferior vena cava right next to it. A little bit lower down into the abdomen, you see abdominal muscles. You can see bowel gas. This person's got some infection going on over there. And then these big muscles right there are the psoas muscles, the ones you see on the x-ray that run down right next to the spine and hook into the trochanters. So you can see the psoas muscles right there. I put this up there because the adrenal glands are important for you to be able to identify, at least know where they are. The adrenal glands sit on top of the kidneys, and if you do a dry chest CT, you have to include those. So when you're doing your scan, when you scan down, as soon as you see the top of the kidneys, you can stop because you know you got control. They kind of look like little stars on an x-ray. And then the pelvis. Remember, things in the pelvis are still going to be oriented with the anterior stuff on the top, posterior stuff in the back. With the male patient, you got a bladder, and then you usually have the prostate and the rectum. And with a female patient, you have the bladder, and then you either have uterus, vagina, depending on how high up or low you are, and then rectum at the back, sacrum all the way back behind that. see if we got it all. I think we did. Yeah, we did. Okay, good. All right, everybody take out their phones. We'll play a quick game and then we'll be done. Probably take 10 minutes to play. Any questions on that before we play our game? I know it was quick.
You won't be tested on that this week, no worries. But I just wanted to give you guys just a little bit of a foundation before you go to clinical. But we'll have, because we won't talk about anatomy again until next semester. So I have this PowerPoint posted that Rick gave you, and like I said, I would start just looking in your sectional anatomy workbook and just, familiarizing yourself so that you don't wait until next semester and then you're kind of pressured to learn everything all at one time.
All right, so go to your phones and just make sure you're on the Wi-Fi and then type in Kahoot It, K-A-H-O-O-T-I-T. Whoops. I always throw some stuff in about the Orioles and Ravens, so you have to get up on that a little bit. So when this done, you're going to put that code in. 347. Kahoot It. It's usually the first one that comes up. We'll make sure everybody sees the more points that you're going to get. 12 questions. Keep them to yourself. Okay, yeah, the Orioles are currently in last place, so yeah, that's okay. They're rebuilding, right?
They're always in line.
They have plenty of, look, I picked this picture, and I think we only have Chris Davis left on our team. This was from a couple years ago, so anyway. Okay, Kelly's in first with 964. Good job. All right, next question. As soon as the last person has submitted, the answer comes right up, so we don't have to wait for 20 seconds. So that's a good thing. So remember, axial, transverse, horizontal all mean the same thing. Who knows what that blue arrow is pointing to? That is a neck CT. That was obtained in an axial plane. You ever go to the doctors when you get sick and the doctors start poking around under here? What are they poking? Sort of. Yeah, they are. They're glands. What's the biggest gland? The parotid gland. So on a CT, the largest ones that kind of show up out here are the parotid. You got your parotid, you got your submandibular, right? You got the ones under the tongue, right? The biggest ones are the parotid, and they show up out here, and they're a lot darker than the surrounding tissue, and they are vascular too. Okay. Very good. Uh-oh. Josh pulled in the lead. Yeah, we don't obtain the scan in the sagittal plane. They do MRs, by the way. They actually scan people in the sagittal plane in MR. Yeah. In CT, the main way that we scan people are in a transverse plane, which is the same as axial, same as horizontal. Remember that load from Brent? That's the way the person moves through the scanner.
Fourth place? I'm all right. Am I not fast enough?
Are you Slice?
Yeah.
I wasn't even looking at that. Okay.
They're young, they can read fast.
Yeah, they have better reflexes than us, no doubt.
Getting this one on you.
Two people got that one. I mean, two answers are correct for that because remember, frontal and coronal are the same. So you could select either one of those. So when you looked at that, it's just like kind of like the one I showed you. When you can see like the eyes, the arches, the sinuses, part of the like the jaw and the teeth, all kind of straight down like that, you know it's a coronal plane or a frontal plane, right? Now when they did their reformats, they didn't do them exactly right because it's not symmetrical. Look how like this arch is a little bit closer to the outer orbital wall than that one. So they would have to make some adjustments to make sure that you get them straight. So when you do your reformats, look at things like that to make sure you get them straight. Don't put them through that don't look symmetrical. It's harder to diagnose a fracture if it's not symmetrical. Okay. Yeah, it would have to say divides into equal right and left halves, not just left and right. Because a sagittal doesn't necessarily go dead down the center. A mid-sagittal would, but a sagittal just divides either the body or a part. Like if you're just doing the arm, you can cut the arm into sagittal sections, right? Is that mid-sagittal? Hell no, of course it's not, because if it was, you'd see the vertebral bodies, right? And you're hardly seeing any. You're seeing some of the spinous processes, a little bit of the body here, a body there. Probably was obtained with the patient laying slightly crooked, because you're seeing a vertebral body here and then none there, right? Maybe their neck's a little crooked, like spasming, something like that. That's why it didn't come out straight. So that was taken as a sagittal section, but not dead down the center. Uh-oh, Mama Cox. Remember you put that on yours one time?
I did.
Yes, you did.
I also put boobs up there before too.
You did?
Yeah.
I don't remember that.
Kelly didn't kick me out.
Oh,
It was with Kelly.
okay. All right, so the blue arrow there is pointing to these white dots. Remember I said that as you get older, the choroid plexus get really calcified and show up bright white. So that's where the cerebrospinal fluid is made. I had a couple other things to mention about that. The term cistern that's there, where it says cisterns, anything in the brain that is like a large area that holds spinal fluid that's not a ventricle is usually a cistern. And some of those have like specific names. We'll go over them more in detail when we have our class. But if you see an area and it's not exactly like where a ventricle should be, but it's bigger than a sulcus, it's probably a cistern. So anterior horns of the lateral ventricles, third ventricle, choroid plexus. These are posterior horns of the lateral ventricle, cerebellum coming in. See that? That mouth? That's actually a cistern right there. It's like the quadrigeminal cistern right near the quadrigeminal plate. So it's holding spinal fluid. It's not one of the ventricles. This is a central sulcus. Okay. Lead keeps changing. Yeah, everybody got it right. You know, I thought some people were going to pick longitudinal fissure, because remember I said that the falx lies within the fissure? But it is actually pointing to the falx, isn't it? Like the end of the blue tip of the arrow is right on that white thing. If somebody picked longitudinal fissure, it would have been incorrect, but it does lie within the longitudinal fissure. How about this? I put inferior sagittal sinus. Anybody know what the blood vessels are called in the head that carry deoxygenated blood? There's arteries in there, right? There's arteries in the brain that carry oxygenated blood, and then there's veins in the brain, but they don't call them veins. They call them something else. Sinuses, remember that? And we have the superior sagittal sinus and we have the inferior sagittal sinus. The superior one is really the only one that really shows up on a head. The inferior doesn't, it's really small. But the superior sagittal sinus runs from the top here all the way back to here. Runs along the very top of the head within the longitudinal fissure also. Uh-oh. Uh-oh.
You're on fire.
You're on fire because you've moved up to second, Deb. You still have a chance to win this. All right, here we go. All right, so again, pulmonary trunk, right? Pulmonary trunk turns into the right and left pulmonary artery. So the pulmonary trunk is at the same level as the carina. It's the same one that I used in the lecture. So carina. Kind of still in the lead. McKenna's hot. I said the esophagus rarely has air in it. That one's got a little bit, doesn't it? It's got a little bit of air in there. Normally no, because usually it's collapsed, but every once in a while, right, people burp, don't they? Or swallow. Yeah, sometimes air gets in there a little bit. Somebody picked trachea, somebody picked carina. Okay, so.
My best. My best.
All right. It's
In
okay.
my defense, you said it doesn't have air.
It said it usually doesn't. All right, here we go. So again, the arrow is pointing to the adrenal glands, which sits towards the upper poles or directly above the kidneys. Pelvis, the thing that would be right in the front, no matter male or female, would be the bladder. Bladder's right in the front. Bladder, prostate on a male, female. Seminal vesicles would be slightly above that. And sometimes you wouldn't see the prostate, you'd see those instead if you're a little bit higher up. And then female, again, uterus or vagina, and then rectum in the back. Okay. McKenna's running away with this now. You really have to screw up to lose, I think. I even gave you a picture of the Dolphins from Miami.
Oh my God.
So they open up against the Miami Dolphins. So
I don't
McKenna, you won. Very good. Okay. Thank you guys for letting me come in and give you a little introduction. If you happen to see something that you can't remember, don't hesitate to contact me. I can surely help you figure out what it was. Then we could probably stop the recording unless you want to keep recording. Yeah, hit stop. Good. You want to upload it for me?
Yes,
I'm just taking that out.
I want to accept it.
Did you guys have any questions? Basic anatomy, planes, anything before I leave? Thank you, guys. Looking forward to teaching you. Should be fun. Thank you, Debbie, for letting me
Thank
do that.
you.
I know you guys would rather just have like hours worth of classes than do with me. They're always fun. All right, I'll see you guys.
All right, thanks, Rick.
You're welcome.
All right, so I'm just going to get through a couple more things real quick, and then we'll have questions, and then we'll get out of here. Just a little bit about CT. We do not call CT a CAT scan. Everybody will call it a CAT scan. The correct terminology is CT scan because we're computed tomography. We're not computerized axial tomography anymore because we can scan in several planes. So the RSNA established that the correct term to be used is computed tomography. So although for ever and ever and ever, people are going to say CAT scan, but you guys know that the correct term is computed tomography. A little bit of history about CT, and when you get into the physics, Kamal's going to go over all the generations of CT scans. But basically, Godfrey Hounsfield developed the CT scanner. In 1967, Hounsfield began his research. Hounsfield, this is an interesting point, he was a mechanical engineer and he worked for a company called EMI, which was a British electronics company. And for some reason, while he was working, he discovered that if you passed x-rays through an object in all different directions and took measurements of the transmissions, that information could be obtained from about the internal structures. So x-ray had been around for a while. You guys know x-rays have been around since like 1895. Rankin developed x-ray. And you could see the external structures of, like if you took an x-ray of the skull, we could see the skull, but we couldn't see what was inside the skull. So Hounsfield in his lab at EMI was piddling around and discovered this and went to the people, his supervisors, and he said, I think I'm onto something here, but I need money for research to research this to really prove that I can, visualize internal structures of an organ. So they told him, we don't have any money, but we're getting ready to sign a band. Their name is the Beatles, and if they make us any money, we will fund your research. So, of course, the Beatles went on to make oodles and noodles of money. They funded Hounsfield's research, and voila, CT was invented. So you can thank the Beatles for that.
Wait, EMI the record label?
Huh?
EMI the record label?
Mm-hmm.
Wow, I never knew that.
So anyway, this was the first CT scan. They were scanning this woman who they thought had a brain tumor, but they didn't know. So they did this scan. It took like 6 hours or something to get like 2 slices. And lo and behold, you can see here that on this terrible image with horrible resolution, that there is, in fact, a tumor there. Just a little bit about some terms that you might hear when you're at clinical. You might hear different resolution terms. You might hear spatial resolution, which is the ability of the system to define small objects. So spatial resolution is really going to be your detail. Then there's contrast resolution. That's the ability of the system to differentiate a structure from its surroundings. So if better contrast resolution means that when two things are kind of the same color on a CT, 2 different shades of gray, the better the contrast resolution, the easier it is for you to distinguish 2 things from each other. And then temporal resolution refers to the speed that the data can be required. So some systems are going to have better temporal resolution because they're faster scanners. And then you can see from one of the first CT scans to a more up-to-date one how much better that the resolution is, obviously. Image quality has definitely improved, and all of the resolution has improved, and also scan time has really decreased from, it took hours in the beginning to do a CT scan. Now we can scan ahead in probably 5 seconds. So obviously temporal resolution has really improved. And this is kind of, this is a scanner from the olden days, but really things haven't really changed. I mean, there's still a couch, there's still the gantry. The gantry, there's still an opening for the patient to go through, although things have gotten a little bit different. Basically, things are still the same. Inside of here is the tube with the detectors. Initially, there was a tube with only one detector, and it would have to go all the way around the patient. Now there's hundreds and thousands of detectors that we use in CT now. And you can see, initially, all that was ever done in the very beginning when they first invented CT was all they scanned was heads. But then as time went on, they did start to do body CT. This is what, if you open the scanner up, this is what the inside looks like. Pull up the gantry in the front, and you can see there's the x-ray tube. There's a cooling system in here. You have your generator, and you have the detector array that kind of goes around the patient. Just a little bit about CT utilization in the U.S. You can see that back in 2011, the number of CT procedures peaked. It went way up. And then 2012, 2013, 2014, kind of things started like going down. Does anybody know why that happened? Had a big surge and all these CT scans, and then all the numbers started dropping. It's because of the media. The media puts out something and says CT are bad, radiation's bad, and then everybody goes crazy and freaking out, and they go to get their mammogram, and they want a thyroid shield, and they want a waist shield, and everybody's afraid because the media gets everything into such a frenzy. So when that happened, the manufacturers were like, we need to do something. This is not good because there's patients that need to have CT scans that now are scared to have them because they're afraid of the radiation dose. So they came up with all of these different pledges that you can make, all of these different websites that you can go to. There's Image Gently, where there's just protocols specifically for pediatric patients. There's also Image Wisely, where you can go on and you can take the pledge and sign the paper saying that I will always follow ALARA and I will never overexpose people and I will use the lowest dose possible to get my images. Then there's also Choosing Widely. The American Board of Internal Medicine came up with this one, and this one helps clinicians when they need to order exams. It helps them to know which exam would be best to order. The CT vendors also responded as well. They started using automatic tube current modulation, meaning that the scanner, and we'll talk about this way more in physics, but you have this software now where the scanner knows when it's in the lungs, it doesn't need as much technique, but as it goes down into the abdomen, it needs to increase, and then it goes down into a thinner part, it needs to decrease. So that's automatic tube modulation. There's also AEC. You guys are used to AEC for X-ray. There's AEC for CT. There's also Smart MA, Care Dose. There's much improved detector efficiency now. There's dual energy CT, there's iterative reconstruction, all these things we're going to go over, but I just wanted you to know that the vendors are aware that people are freaking out about dose, and there's lots of things that they have done to help decrease dose. Multi-slice scanners, let's see. I want to show you guys something.
Okay.
The patient can't obviously see this, but this is kind of what's in
Go ahead, you gonna get a movie? Scene one, take 5.
If I want to get in there. After I saw that. Requires so many images in short amounts of time.
Crazy. Yeah.
Spending all of your 16 That's Rick's. And then I just threw some images in here, sagittal, coronal, axials. There, we do a lot of CTA. You guys might hear that term, CT angiography. We do a lot of CT angiography studies now. We haven't really taken over for angiography. It's still the standard way that, you know, things are diagnosed. But CT angiography has really come a long way. And hopefully maybe one day patients will be having CTAs instead of going in and having exams in interventional. But you can see that we can see the vessels. We can take the vessel, a curved vessel, and straighten it out so that we can see it. CT is great for bony detail. The question that people are going to ask you, your family, well, what's better, CT or MRI? And what's the answer to that question? It depends on what you're looking for. If you're looking for bony detail, CT definitely. MR is not good for bony detail. MR is good for soft tissue. It's good for nerves and tendons and things that we can't see. But for bony detail, so it all really depends on what you're looking at. CT is way better for lungs than MR. MR is way better for certain things than we are. So we complement each other. So not one is better than the other. It really just depends on what you're looking at. Has anybody taken an x-ray of a sternum? You can't see a darn thing, right? Can you see the sternum? Yeah, well, on CT, we can reformat, a coronal reformat, and we can get a beautiful sternum. We can do subtractions too. We can look at the vessels only and take the bone out. Or we can just take the bone out and look at the hardware. So we can do subtractions on CT. Has anybody, you probably haven't seen yet, did you see calcium scorings already? Two today? Okay. Yeah, calcium scorings, when they look at the vessels in the heart to see if there's calcium, and then they score it depending on a lot of things, your age, demographics, things like that. Just some of the anatomy coming off of the heart here. Left coronary, your circumflex, your left anterior descending, your right. And this is where they look to see if there's calcium. 3D heart. Virtual colonoscopy hasn't, again, something that we can do but hasn't really taken off. We thought it would, and it really didn't, because you still have to do prep for this. You still have to kind of clean your bowels out, which is probably the worst part of getting a colonoscopy for people. Also, if you have virtual colonoscopy done in CT and they see a polyp or something, they're going to send you to have regular colonoscopy so that they can biopsy it. So if it's normal, you've saved yourself, you know, having a colonoscopy done. But if it's not and they see something, then you have to go. So people are like, well, why go through all that prep and everything if I have to end up doing it twice? So people just still go for the golden standard, which is colonoscopy. But virtual colonoscopy is out there, and you may see it at some of the sites that you're at. Always use a Laura. Okay. So anybody have any questions about anything? Okay, so this week you have a couple of assignments due. Remember we talked about what's due in week 1. In didactic, you have your discussion board, and I only do a discussion board in week 1 so that you guys can learn how to use the discussion board. So basically, it's an introduction discussion board. So you have to post to the discussion board, watch those CT the Basics modules that I asked you to watch, sign those papers and turn them in next week if you didn't sign them and turn them in already. No quiz this week. Review your handbooks. It's really all the assignments that you have. So then next week will be our venipuncture lecture. Have venipuncture, we'll have the mannequin set up, we'll go over assessing patients and things like that, because I want to do that early so that when you guys are in clinical that you know how to do that. I will also open up the contrast week so you guys can see what that assignment is about interviewing a patient and bringing that, because everybody will present. I think it was July the 25th, so I want to give you guys at least 2 weeks and 4 days of clinical to kind of get that done. Any questions? How did your clinical go? Did you go yet?
No, mine is this weekend.
That's this weekend. Okay. So everybody's gone except Sandra on the phone. So you'll tell us next week how yours turned out. Okay. Any other questions, comments about anything? Okay. All right. Well, I will see you all next